So my focus primarily will be on small bowel perforation, but for completion's sake, we start with the duodenal perforation, go on. Now we start with duodenal perforation. I'm sure all of you have seen this. Many of you would have performed operations on this. Again, I'm going to talk only on open surgery. A lot of duodenal perforations are being closed by the laparoscopic method. It's left to you. You got an adequate experience. You'll be able to. Now, the first point I want to impress is this. This is my concept. See, most of the chronic duodenal ulcers that were being operated in the past, and I'm told even now in places like Tamil Nadu, are posteriorly located ulcers. They cause so much cicatrization that ultimately they end up with a duodenal stenosis. What we are seeing today is more like an acute perforation. I compare this to erosive gastritis that happens in the stomach where the submucous vessels bleed. There's an erosion of the mucous membrane. Submucous, there are plenty of blood vessels. They start bleeding. The olden days, they were called as acute gastric ulcer. We don't use that term. It's now erosive gastritis. To my mind, perforations occur in a similar situation in the duodenum. Time ago, certain new and anti-inflammatory drugs were NSAIDs were introduced. At that time, we had a huge number of perforation drug-induced. Those drugs have been withdrawn. I won't mention them. But my concept is akin to erosive gastritis. You have a acute duodenal ulcer anteriorly placed, and that is the one that is likely to perforate. Simple reason, duodenal wall is much thinner than the gastric wall. What you should remember, I'm sure all the seniors would have assisted you for a perforation or when you do. What is important when you start trying to close the perforation? What is it you're warned against? Come on, quick, PGs. Mr. Banerjee, please. What is it you're warned against when you close, maybe open or laparoscopy, any technique? What is it you're warned against? Come on, quick.
Tension free.
Tension free. That is like tension when you tie. Before that, okay, I'll give a clue. Citing sutures. Okay, I'll give Sandesh. Citing of a suture. The next point is that you can see that the edges are edematous and friable. That again indicates that you're dealing with an acute pathology. That's why when you're trying to close a perforation, you start from a point, healthy wall of the duodenum, placed a little away from the edge of the perforation. Again, on the distal side, you go a little beyond. If you take a suture close by, chances are the sutures will cut through. That's why I've written that edematous and friable edges. Of course, the classical method all of you are aware of, convert this into a vertical opening, something like a pyloroplasty, and you close it. Usually 3 stitches are adequate for most of perforations. Go well away, leave the ends long. Of course, I use 2-0-Vicryl on a 30 mm needle. Once you close, put a mental pad. There's some discussion in the Facebook recently. We learned only one name, Roscoe Graham. There's some many more names I'm not aware of. I'm very poor, but as far as names are concerned, what is important is now tension, you're not going to strangulate the omental patch. You must tie them with just enough pressure to keep the omentum in place and from slipping away. There's an omental pad that adds to the strength to your closure, and following which you have to put them on. Before that, sometimes the perforations are large. I have done only 2 of these. One was a perforation closed and recurred again, and second was a large perforation. Mobilize the duodenum by a Cocker maneuver completely, right from detach the hepatic flexure, see the whole C-curve of the duodenum is freed, and mobilize it, and then enlarge the incision and do a Finis pyloroplasty. It is not as easy as it sounds, because you have to make sure that at the end point, you're not going to cause any kink in the duodenum. Next point is only for information, but I heard one of the most senior respected teachers from Chennai used to come to Manipal in the 1980s and early 90s, Professor Sharat Chandra. He used to say there are occasions when the perforation is so large that he had to use the great momentum to pack the whole opening and add on a GJ. I have not done it. Following a GJ, those days, they were scared to do a vagotomy because in the presence of sepsis, you open up the mediastinum, there's always a scare of a mediastinitis. And those patients probably needed medication later on. I have not practiced it, but this is described, it was described by such a senior respected teacher that I got to mention it. I have not done it. So second and third options are rare to be used with a bit of expertise, whereas a closure can be done provided you take a bite a little far away from the edges. That's why I've stressed on the edematous friable edges. Following this, you put them on anti-ulcer treatment. You treat the H. pylori and then put them on whatever drugs you want. And what surprises you, if you repeat the endoscopy at the end of 6 weeks, you'll find an absolutely healthy, normal duodenum, indicating again that you're dealing with acute perforation. There is a time before endoscope came into being, all patients with duodenal perforation came back for an elective truncal vagotomy GJ 6 to 8 weeks or 3 months later. It was taken for granted that the ulcer will persist and such patient need a surgery. I still remember a college mate of mine presented more than 400 cases at an, from Nagpur at an annual conference. To my mind, that is an overkill. You put a scope at the end of 6 to 8 weeks, you will not make out any evidence of a previous perforation. There is no distortion. Entry into the first part of the bulb is very easy. The bulb looks very healthy. Unless the patient goes back to whatever causative factors, these people do very well. So drug duodenal perforation is comparatively straightforward. Only thing is delay causes a lot more damage. Point number 2, the amount of rigidity that you see in duodenal perforation is rarely seen in other perforations. Why? These are the so-called board-like rigidity that you expect in a peritonitis. When an ordinary third-year medical student, he puts a hand onto the abdomen, he says this abdomen is rigid. The word board-like is used in relation to a wooden board, as if a wooden board is kept under the abdominal skin. That kind of rigidity is very, very characteristic of a duodenal perforation. You don't see this extent of rigidity of other perforations. Why? Sandesh. Quick. 2AS.
Chemical peritonitis.
Good, excellent, very good. First 24 hours purely chemical, then only it becomes bacterial. So this chemical peritonitis induces so much a reaction of abdominal muscles. Understand that? So that's why you find board-like rigidity. And one more point, I didn't mention it here. Don't ask for a plain X-ray abdomen. Always ask for a chest X-ray, because chest X-ray, the diaphragm is well seen, the gas underneath is also well seen. When the patient is very sick, what to do? I'll do it a little later. Shifting a patient erect position has certain contraindications. We'll discuss that a little later, but this is one of the easiest surgical emergencies to identify in a patient who usually does not give history of previous peptic ulcer, comes with an emergency, board-like rigidity, loss of liver dullness on percussion, presence of gas and diaphragm on X-ray, straightforward diagnosis, and you close the perforation, they do extremely well. Gastric perforation, on the other hand, are compared less common. What are the, number 1, the gastric wall is much thicker. Number 2, most of the gastric ulcer by the time they reach a surgeon are chronic with plenty of fibrosis. Bleeds are common. A life-threatening bleed from a lesser curvature gastric ulcer comes from which vessel? Life-threatening bleed from elderly patient, more female.
Gastroduodenal.
Gastroduodenal artery. Where does it run, Missy? I'm talking lesser curvature gastric ulcer.
So left gastric.
Left gastric artery is almost a direct branch of aorta because celiac axis is such a small trunk. The left gastric, for all practical purposes, is a direct branch from the abdominal aorta. That's why you have life-threatening bleed. I won't discuss how to bleed a gastric ulcer, obviously, here. Treat a bleeding ulcer. Now, biopsy is mandatory, irrespective of how benign it looks. Always take an edge biopsy. Understand? Uncommonly, you see malignant perforation. In fact, I don't know whether we had the dubious distinction of presenting 20 cases of malignant gastric ulcer perforation some years in the annual conference of ASI. That means our patients wait till such a late stage that they come with their perforation, and on table you find a large growth, obviously malignant, and we have done a palliative gastrectomy. You know what the results are going to be. But second point is, when you see a gastric perforation at an uncommon site, greater curvature, I think I already mentioned the 3 common sites. Am I right? No need to repeat, no? Many people have heard this before. And you have lesser curvature 1, prepyloric region 2, junction of the body antrum 3. I've given the explanation last time. So if you find perforated gastric ulcer at other sites, chances are it's being malignant. Right. Now, simple closure is mentioned only to be condemned. There's so much of chronic fibrosis and the quantum of vascularity is so poor. At least minimum required is a wedge resection of the ulcer along the edges until you reach. Luckily, stomach is quite a large organ. You can sacrifice a part of it without any problem, and a wedge resection is the minimum you do, and send the whole specimen again for histopathology, even if you've taken biopsy earlier. Then such patients who undergone a wedge resection need anti-ulcer medication, but stress is on repeat endoscopy. What is the percentage of malignancy in a benign gastric ulcer as it stands in the year of our Lord 2020? Come quick.
5%.
Yes, please.
5%, sir.
5%, right? Go on. It's like an auction. We can go up or come down. It's like an auction. Quick, quick, quick. One answer I got is 5%. Gentleman is writing. What happens, sometimes it passes directly from my tongue onto a pen and down to the book, bypassing your gray cells. You must listen first and then write. Okay. Come on, quick. Are we stuck at 5%? Is it a universal opinion? I like dissenters. Yes? Are we going up or coming down? Are we going up or coming down?
10%.
15. We have gone up. Oh, good. Very good.
10%.
10%. Okay. First of all, you are aware that in the last 5 decades, treatment of peptic ulcer undergone a, I would say, magical transformation. We used to have only Gelusil, Digene, and some antibiotics. Today got H2 blockers, PPIs. In fact, the latest figures I have is over 0.2%. I'm not sure whether that is also accurate. Maybe it may be still further down. First of all, number of chronic gastric ulcers seen in endoscopy has come down considerably compared to duodenal ulcer. Olden days used to say 1:30. To my mind, it's probably the percentage even higher. Those ulcers which perforate again are much become malignant are much less because excellent medication and repeated endoscopy will show that percentage much less. But you must be aware of it. If the patient is stable enough, I would suggest a partial gastrectomy. These are patients where you try to remove what is called as the ulcer-bearing area of the stomach. That means you take out most of the lesser curvature, most entire antrum, and a minor portion of body. And I, for one, preferred Billroth 1 reconstruction, that is a gastro-duodenostomy. What I did was to redo the lesser curvature and then reduce the opening in the remnant of the stomach to that of the duodenum. Do a coccus maneuver. You can bring the duodenum almost up to the midline and do a beautiful gastro-duodenostomy. Decades ago, when we presented our experience with 50 cases of gastric ulcer, a very, very senior surgeon, unfortunately, I was stuck with the MS exam. My associate came and presented the case in Chennai only. I don't know which conference. A very senior surgeon, respected surgeon, said, "You are lucky." But we wanted to prove that the angle of sorrow, well looked after, doesn't really mean a leak. It is feasible, and a gastro-duodenal anastomosis far better physiologically than a Wilrod 2. But you have got to choose your patients carefully. If the patient is very sick with signs of obvious peritonitis, don't venture into major surgery, do a wedge resection, put them on anti-ulcerative. Now the question is, you have done a wedge resection, biopsy report comes malignant. What to do? What to do? You thought it was benign, you did a wedge resection and sent the whole material. Report is malignant. Beg your pardon? Loud, Vidya, I suppose. Loud.
No revisional surgery, sir, because it's already spread. It perforated.
That's a bit of specific. I agree with you. Outlook is very poor because once a gastric malignancy or any malignancy in the abdomen erupts on the serosa, the whole peritoneal cavity is open for dissemination. To that extent, the outlook is poor. But I'm sure today's youngsters are much more aggressive. I don't think they'll take such a pessimistic attitude. There's a place for so many new lines of treatment. Therefore, probably one would go in and do a gastrectomy, not do a radical gastrectomy, taking out D2, etc., etc. But I think it's safer to take out that portion. At least you reduce the risk of bleeding, perforation, obstruction, etc. at a later stage, and then treat him like an advanced gastric malignancy. You are perfectly right. Once the tumor erupts on the perforation means already come onto serosa, outlook is extremely poor. Go to jejunal perforation, extremely uncommon. Where do they occur? Anybody has an idea?
Diverticulitis.
Right.
Zollinger-Ellison, sir.
Beg your pardon?
Zollinger-Ellison.
Zollinger-Ellison, where do ulcers occur?
D3 and D.
I didn't hear.
D2 and D3, sir.
D2 and D3, how often do they perform? This Zollinger-Ellison syndrome comes with acute manifestations, multiple ulcers. D2, D3 are not the only site. You'll have enough ulcers in the stomach. Then the treatment, you look at the primary cause for Zollinger-Ellison and treat. Understand? There are days when we did not know the full pathophysiology. I myself have done a total gastrectomy for a Zollinger-Ellison. But today I think it's considered too radical. You have a lot more avenues to treat patients with Zollinger-Ellison. Now, jejunal perfective. Why does the diverticulum perforate?
Wall is thin.
Beg your pardon?
Wall is thin and it gets stretched.
Wall is thin. Can you explain it?
Diverticulum.
So you're on the right path. So unlike the jejunal,
It is a false diverticulum.
there is no muscular layer in the diverticular wall. There's a PG. That is what you expected to say. Understand? So mucosa, submucosa, subserosa, serosa over. There's no muscular layer. The wall is much thinner. Diverticulitis can lead to perforation. Why does diverticulitis take place? Because bacterial contents have no exit. Understand? They tend to accumulate inside. And then the next picture will show you that. And treatment would be
Resection and anastomosis.
Resection and anastomosis.
More often than not, as the picture shows, you can see the perforation there, but more often than not, these patients have multiple jejunal diverticuli. How to treat it's a beyond today's discussion. But you must be aware of the problems faced by multiple jejunal diverticulosis. Now, why does tuberculosis of the intestine produce perforation? Tuberculosis is a chronic disease, leads to fibrosis and stricture. We already learned, am I right? Because
Yes.
the lymphatic
Ulcerative tuberculosis can produce perforation.
leads to perforation. That's what I'm trying to tell you, my dear girl. Tuberculosis is a chronic disease. And there is thickening, because we discussed last time, the lymphatic accompany the blood vessels. So therefore, they are in a circle all around the circumference. And these tubercles coalesce together. Healing occurs by fibrosis. You get stricture. That is stage
Through Peyer's patches.
Peyer's patches, you have gone too far down. And yeah, congratulations. Every time it's Vidya, is it? Good.
Yes.
Keep up. It's good to have this kind of imagination. I would love to hear wrong answers because at least you are bold enough to open your mouth. That's a very good quality in a PG student. Amog, as the name says, must have a lot of knowledge. Amog, come on. Amog means plenty. Quick, quick. Yes, brother, familiar name. Sorry, I'm not saying a face.
Obstruction leading to perforation.
Obstruction. Now you're on the right path. Therefore, perforation occurs in the proximal dilated segment, which gets thinned out for a period of time. And please remember, perforation in tuberculosis is in the proximal dilated, thinned out portion and not at the site of the ulcer. That's the reason I brought this. Understand that? And what is important is more often these are seen in the ileum. The content that leak out, the bacterial concentration is much higher. They have gross more risk of severe peritonitis. Treatment. Before you treat, read the next word. You must look at the rest of the bowel because isolated single strictures in tuberculosis are uncommon. I'm not talking about ileocecal tuberculosis, please. That's a totally different entity. I think Rajagopal Shane must have talked about it already. I'm talking small bowel tuberculosis, most are multiple. I think we went through this path earlier. I said the bacteria are bovine in nature, is supposed to come from drinking unpasteurized milk. Bovine bacteria withstand the acid content of the stomach because that acid fast coating and go down the small bowel and they produce multiple lesions ending up with multiple strictures. Proximal to the stricture, the bowel dilates. So kindly look at the rest of the small intestine. Let us look at one simple, only one stricture, proximal dilated segment perforation. Treatment. Quick.
Resection and anastomosis.
That's right, resection anastomosis. Resect the thinned out part. Please remember that. Thinned out portions are poor material for anastomosis. Understand that? Maybe a few more inches until you reach healthy bowel and anastomosis again to healthy bowel. Thereby, you reduce the risk of leakage. Multiple strictures, treatment is differs, stricturoplasty or by. People tend to avoid bypass because of the risk of, what does bypass small bowel bring about? What's the risk?
Blind loop.
Blind loop syndrome.
That's correct. All these patients, of course, need ATT in the postoperative period, right? Now we come to typhoid. This is the main reason I took up this topic because in this country, typhoid fever is still common and unfortunately, a small number do perforate. Time frame, when does perforation occur in typhoid fever?
Second to third week.
Third week.
Right.
Third week.
Okay. Anytime late second week to third week is a perfectly right answer. Site.
Ileum, sir.
Ileum.
Why ileum?
Payers patches,
Payers
sir.
patches.
Most of the
The
typhoid.
typhoid bacilli get focused on the lymphoid patches. That's why the terminal ileum is one area, right? Number?
Solitary, 80%.
Huh?
80% solitary.
80 solitary.
Perforation is solitary, sir. 80% of the perforations are solitary.
Unfortunately, this is one condition where you can get more than one perforation because lymphoid patches are distributed along the terminal ileum and delay in diagnosis. The main reason is delay in diagnosis. Of course, today you got one advantage. At the GP level, they start with the highest level of antibiotic and then come down. The moment the patient is fewer, they start with the highest level. But even then, perforations do occur. So it can involve the rest of the ileum. And again, the contents are likely to be a lot of endotoxemia because the gram-negative bacteria produce endotoxin and toxemia does occur. So contents have a high bacterial count. Right. Now here comes the problem. First point to remember, these patients appear much sicker compared to the previous case of perforation we have discussed so far. The degree of toxicity is much higher Many of them may be in hypovolemic or toxic shock. Understand that? Then, of course, you have to rule out a condition known as peritonism. What is peritonism? What is peritonism? The clinical picture is one of peritonitis, but there is no peritonitis. Explain. Explain. Now, first of all, before that, there's one other point. In what way does clinical signs in the abdomen is concerned differ in a typhoid perforation compared to other perforations? And purposely, there's a gap there. Clinically,
Presentation.
I said patient is toxic. I'm saying abdominal signs. What abdomen? See, I've given a clue already earlier. Can anybody tell?
Abdomen may be soft.
Huh?
Abdomen will be soft.
Abdomen may
Shock,
be soft, sir.
I already talked about shock.
And there will be no body and rigidity.
Absence of rigidity. Why? Why?
Gentrous degeneration of the skeletal muscle.
Very good. What is Zenker's degeneration? PG level. What do you mean by Zenker's degeneration?
Collagen degeneration.
Collagen?
Destruction of
The primary cause is, I mean, this is only a bit bigger. There is some experimental proof, of course. Increased lactic acid levels are supposed to produce what is called as a waxy or a hyaline degeneration of the skeletal muscle. As at a postgraduate level, you have to know this. Zenker degeneration occurs as a result of excess of lactic acid in the muscle, which leads to a waxy or a hyaline degeneration. Why I'm saying this is, in the at early PG level, soon after MBBS, any abdomen which does not have rigidity, you think it's not a serious case. Any abdomen which does not have rebound tenderness, you don't think it's considered serious. Now I automatically ask you one more question. A patient comes, general condition extremely poor, symptoms are extremely severe. You put a hand onto the abdomen, you're surprised that the clinical signs are conspicuous by their absence. What are the two conditions you think of straight away? 10 seconds. 10, 1, 2, 3, 4, 5, 6, 7.
Mesenteric ischemia.
Mesenteric.
Good. 50%.
Mesenteric ischemia.
Right, agreed. Number 2. 50% right. And the 10 seconds. 1, 2, 3.
Typhoid perforation.
Typhoid perforation. I'm discussing that, Baba, already now. They'll have, I am coming to peritonism. You have to know this. 1, 2, 3, 4.
Ruptured ectopic in females.
Ruptured ectopic.
Ectopic pregnancy in females.
Ruptured. We are in surgery. I dare not enter the pelvis at all. Days gone when I used to assist gynecologists for hysterectomy. You the ancient whip and wing. Today you don't do that.
lax anterior abdominal wall, sir.
My dear people, I don't know what to say. You have to always suspect when the general condition and the systemic signs are very prominent. Absence of abdominal findings, please remember mesenteric artery ischemia. Acute pancreatitis and mesenteric artery ischemia produce minimal signs in the abdomen out of proportion to the systemic symptoms and systemic signs. BP be low, 30 pulse, hypotension, patient looks sick. You put a hand on the abdomen, hardly any finding. Think of these two. Always keep this in the back of the mind. Mesenteric artery ischemia as well as acute pancreatitis. Now we come back to peritonism. Peritonism means we have some suspicion of peritonitis. When does you have rebound tenderness. What does rebound tenderness indicate to you? What is rebound tenderness due to?
Peritoneum.
Sir, irritation to perineum.
When the inflamed bowel wall comes in contact with the parietal peritoneum, you get rebound tenderness. That's why in acute appendicitis, you find that when the parietal peritoneum overlying the appendix gets inflamed, you get rebound tenderness. Understand that? The second is there's always a degree of paralytic ileus in typhoid disease because the intestine is involved. So paralytic ileus and the absence of rigidity with rebound tenderness makes clinically sometimes differentiation of peritonitis to peritoneum is extremely difficult. That is where our friends come into our picture. It is difficult sometimes to distinguish peritonism because peritonism is treated totally conservatively.
So please repeat.
Yes, please.
Sir, please repeat it, please.
What I'm trying to tell you is there are clinical situations where distinction between peritonism and peritonitis can be extremely difficult. Rigidity is absent because Zenker's degeneration. Peritonism also produces rebound tenderness when the inflamed ileum comes in contact with the anterior abdominal wall. Yeah, am I clear now? So you don't see a
Okay, sir.
because paralytic ileus. Rebound
Could you
tenderness
please repeat it, sir?
is absent in both conditions. So there are situations where peritonism and peritonitis can be extremely difficult to distinguish. And these are situations where our friend from the radiology come to rescue. First thing is you look for free gas. Now, please remember, these people are extremely sick and I've seen it happening. I still remember a doctor's wife was admitted 3 a.m. in the morning. And of course, those were when we didn't have mobile phones. They rang up from a place 30 kilometers we are coming. And the duty doctor thought, before I reach the hospital, he wanted to get an X-ray to make sure that the patient had gas and diaphragm. Tilted the X-ray table about 70 degrees plus. What happened? What happened? Alphas disappeared. BP came down because all the blood got pooled in the lower limbs. In fact, those days, much before all your CRP, lactic, etc., one of the methods of identifying shock was to tilt the head under the bed 45 degrees up. If the BP fell down, we knew that the patient was in hypovolemic shock. A very crude method, given up completely. But this doctor's wife, I almost lost her. I was shocked to see her on the X-ray department with her head raised and no pulse, no BP. You don't need to do, what's the option? What is the option? Your ultrasound man refuses to come. You've got X-ray technician only.
Left lateral decubitus.
Right.
Left lateral decubitus.
Why left? Why left? Because the liver is a solid organ. You see this picture now? Can you see the gas so freely? You have the diaphragm on the right-hand corner. You have the solid liver below and you can see gas. So this is without shifting the patient too much, can be done at the bedside with a X-ray machine which can be moved to the bedside. Shifting the patient to the X-ray department and trying to make him erect can be extremely dangerous. Patients can become worse. Of course, today we have ultrasound people. They claim that they can pick out gas much better than the X-ray people. So I got a dedicated ultrasound. Surely you'll get an ultrasound done and the ultrasounds will say there is gas and diaphragm. So under those circumstances, as we learn later, the treatment may be slightly different. When do you do a CT? Is CT indicated, not indicated? Today, CT has become almost a routine for all acute abdominal conditions. CT angiography, CT this, CT that, everywhere. To my mind, there's a very limited indication for CT. I'll come to a little later. You have to remember this. Typhoid perforations differ radically from all other types of perforations. You are dealing with a very sick patient. You are dealing with patient with extreme toxicity. You are dealing maybe with multiple perforation. You are dealing with cross-contamination of peritoneal cavity, and distinction between peritonism and peritonitis can be difficult. This is the primary reason I'm taking this particular session. I want you to understand these points very clearly. No doubts? No doubts? Come on.
Sir,
Okay, thank you.
sir, how will these typhoid ulcer multiple perforation at a single time, sir?
See, please remember, once a typhoid, it's a very good question actually. Once the typhoid bacillus enters the bowel, it tends to localize itself in the lymph patches. Patches are single or multiple? Multiple. So simultaneously, there is aggregation of bacteria along the lymphoid patches. Understand that? I'll show some pictures a little later. Purposely, I didn't want to show the picture at this stage. You have to remember this. Understand that? So this is, which is totally different from your concept of perforations in general. Understand that? Right. So there hardly any, I'll come to a place for CCT as a place. Now we come to treatment. Of course, antimicrobials are necessary. Today we start them on broad spectrum antibiotics, which is really given. Now, is there a place for conservative? Because I already told you, probably I'll have to come back. In the end, I'll mention this. Today, typhoid perforations are still associated with significant morbidity and mortality. So, if you can avoid the laparotomy, you'll be happy. And most of these patients get admitted into the medical wards. Understand that? Yeah. And then they start getting referred to a surgeon. So is there a place for conservative treatment in the typhoid perforation? Answer is yes. A small group of patients who have been admitted into the medical wards, have been diagnosed as typhoid, have been on intravenous antimicrobials and are hemodynamically stable, and the stability continues. Urine output is adequate, patient pain tends to become less, abdominal signs become less. Such patients do very well with conservative. But remember this, they need to be almost at a care that is available in the ICU. They have to be well looked after. If the medical ICU, well and good. And as it's better that I'm sorry, I'm not casting aspersions. There is some delay, in the reference to a surgeon. Make sure that your physicians are friendly with you, and they should refer the moment there is rebound tenderness. I think it's time for a physician to refer the case to a surgeon. Understand that? So those patients who are in right tube aspiration, IV fluids, hemodynamically stable, good urine output, the well looked after medical ward, it's worthwhile trying conservative. Many patients do well with conservative, but those who deteriorate, don't waste time, bring them to OT. There's a place. But those who come with typhoid perforation per se, who had not had any antimicrobial earlier, no question at all, build them up as quickly as possible and then operate. Now comes a treatment. If single perforation, what will you do?
Resection anastomosis.
Resection anastomosis.
Just
Remember,
closure, sir.
I have been stressing on this point. These are very sick people. The less you do, the better for the patient. These are not like
diversion. Diversion, Elias.
Diversion, ileotranscolostomy. Why not close it?
Simple
closure can be done.
No. See, surgeons can never say can. The word can is out of the surgical dictionary. With due apologies to, I'm coming back to physicians again and again. They can always say, I can try chloromycin, I can try erythromycin. No, you can't do that. Here, I'm going to operate. If I'm going to operate, this is what I'm going to do. You've got to tell the patients. Now, remember something which I want to stress. Look at this ulcer. What impresses amount of slough. In a duodenal ulcer, we don't touch the edge of the ulcer at all. We make sure that the surrounding duodenal wall is not friable edematous. I said in the beginning of the class, you take a bite far away from the edge, but look at the amount of slough. A simple closure of a typhoid ulcer invariably needs to reperforation. Can you understand identify the quantum of slough there? Is it visible, please? All that yellow area, see the perforation in the center, but look at the extent of the slough. So unless you excise the edges of the ulcer until you reach a healthy bowel wall, a simple closure is doomed for disaster. This point again must get into your gray cells completely. The slough has been shown purposely to exaggerate, a little exaggeration, but that shows that you just can't close the perforation as you did for a duodenal ulcer. You got to excise the edges until you reach a healthy bowel wall. And that's the next picture, which is ready for closure. The excise, the edges are very healthy. Now, on my right side is the proximal end, the left side is distal end. Where do you start suturing? Proximal end, distal end.
Transversely.
Transversely means what, madam? What will it do? What will you do? You convert this opening which is parallel to the mesentery.
Perpendicular.
Perpendicular. How do you do that?
From the midpoint.
From the midpoint. Now, better to lift up. I think the least traumatic is the back of forceps. Go well beyond the bowel wall, both on the either side of this opening, at the midline, and lift it up. Convert this horizontal longitudinal opening into a vertical opening. And the next picture shows it's ready for suturing, and you see the bites being taken. The opening is almost vertical now, and this is how a closure must be done. Following closure, will you put an omental patch? If so, which type of patch do you prefer? Can you bring the omentum down and wrap it over the perforation in an effort to prevent it from reperforating? Is that advisable? Not advisable? Simple question. Simple question. Quick.
Not advisable.
Not why? Why? You're right. Why? It acts like a band and produces obstruction because you're coming from the greater omentum down to the right ilia fossa. It acts as a band. What about excising a piece of omentum and wrapping over the bowel? There are many surgeons who do it. To my mind, once you deprive the blood supply of the omentum, it does not behave. It's supposed to pick up blood supply from the bowel wall. I have never practiced it, but there are surgeons who still do it. They take a piece of omentum, wrap it over the perforation. And as I said often for many other statements, probably that surgeon sleeps a little better at night. Beyond that, his confidence levels go up. Understand that? Now, next point. I'll go back to this picture, another picture. Look at this picture. Focus on the bowel loop on the extreme right. Can you see an ulcer with slough on the serosal wall? This is an impending perforation. More often than not, you see patches where the lymphoid tissue is involved. First of all, the serosa loses its glistening layer, becomes opaque. Number two, there's a color change. It may appear darkish brown or even almost bordering on the necrotic color. Such circumstances, you do not want to aggravate the condition or wait for reperforation to occur in the post-op period. You invert them with sutures taking the serosa and the muscle. Understand that? So there's a place for inversion of when there's a single perforation. You'll always find patches of lymphoid tissue already diseased, and they're like one of the important cause of postoperative mortality is reperforation in the segment. So wherever there are lymphoid patches, we are likely to perforate. You invert them with a couple of sutures. That doesn't compromise. I make sure that doesn't compromise the lumen, and that is much preferred. Bypass is indicated when there are really verified that the terminal ileum is likely to cause reperforation and peritonitis. Ileotransverse colostomy is not the ideal, but have to be done. I put purposely resection last because that's the most drastic of all procedures. And this is a resected specimen I want you to see. Now, you have resected this. Now, what's the anastomosis like? This segment, the small bowel, has been resected almost. You have gone up to the ileocecal valve. What do you do now?
Ileotransverse.
Ileotransverse colostomy, you're leaving a large blind loop missing. Days when the cecum was not considered to be a safe portion for anastomosis is no longer valid. Understand? You've got a valid point. Why were you suggesting ileotransverse colostomy? Why is transverse colostomy preferred as a site for most anastomosis involved in the colon? Basics.
Vasculature.
What? Basic undergraduate question is extended. Surgeons prefer
most mobile part
colon or the sigmoid colon as the preferred area for anastomosis involving the large bowel. Why?
Most mobile part.
Form the stools are
My hearts are increasing in number. My hearts are increasing in number. It is said that a complete peritoneal covering is the best guarantee against leaks. Ascending colon, a fixed cecum, and the descending colon are devoid of peritoneum in the posterior half. Understand that? In the days gone by, when antimicrobials were few and not very successful, surgeons used to sacrifice large portions of the colon for the simple fact they were devoid of peritoneal covering. This particular aspect of surgery is no longer valid. All you have to do is to, of course, the second point is anastomosing a mobile part of the bowel to a fixed part of the bowel leads to leaks. In fact, that's one of the problems we face at the other end. When you anastomose jejunum to the esophagus, this is one of the problems that we face. There are many other problems, but traditionally, 2 points were given for excising healthy bowel in the past or using the transverse and the sigmoid for anastomosis, where number 1, both were mobile, number 2, both had a complete peritoneal covering. Today, an ileocecal anastomosis done properly is safe. If the cecum appears to be fixed, make an incision in the paracolic region, mobilize the cecum, so it fixed, and cecum becomes mobile, and use an incision along the anterior tinea coli and bring the jejunum anastomose to the cecum. It is very, very safe. Understand that? There's no need to jump and create, you close ileocecal region and then transverse you're leaving a large blind loop, which is no longer necessary. I've done many and they're very safe. The only thing is, if the God has given the patient a mobile cecum, be happy, because many cecums are mobile with a complete peritoneal covering. If the cecum is fixed to the post-abdominal wall, all that you need to is incision along the paracolic area and mobilize the cecum. Ileocecal anastomosis is absolutely safe. I want Dr. Radhakrishnan's opinion on this. Agreed, sir?
Yeah, totally agree, sir.
Oh, it's a total agreement. Thank you. Thank you. No, I need, because it's there are 2 generations below me, not 1, 2 generations. So I got to get what is modern, what is accepted. Right. So resection is the last option to be done only when you see a patient like this. See how many perforations. Those who are talking single perforation, young man, can you see at least 3 and
Yes,
4? I'm sorry, 4 and 1/5 is ready to perforate. This is a problem we face. In fact, unless you see what happens to young surgeon, inexperienced surgeon, they would have tackled 8, 10, or even more than that duodenal perforation. The moment you see a perforation, a small bowel, the tendency is to just do a closure. That is disaster. I hope 20 minutes I spent on talking of typhoid perforation, because this is something we still see. We still have to know how typhoid perforations radically differ in their causation, in their manifestation, as well as the treatment. I want to run 3 important aspects here. Lymphoid patches, therefore, can be multiple. Toxicity is very high. Simple closure without excising the necrotic edges is disastrous. Try to do the minimum possible. Avoid dissection unless it becomes absolutely necessary. These are carry-home messages. Even if I got everything else about today's class, I don't mind. But these are carry-home. Why I'm saying this is, more often than at midnight, you're a senior resident, you may be the only surgeon available. I don't think a chief will, the senior associate will come and say, you close the perforation, Baba, and the phone goes down. That's the end of it. So you got to know really properly well how to tackle a typhoid perforation. If there are any doubts, please get it cleared right now. Okay, silence is golden. Now, there is a condition again we meet with more often in tropics, non-specific ileal perforation. We still do not know why. Non-specific ileal ulcers are more often single. Their etiology is not well known, but what is important is they come with a fever of about 7 to 10 days, but they appear much more healthier compared to patients with typhoid perforation. That's the first thing to do. The general condition appears to be much better. The sign, more often these are open to the diagnosis of peritonitis with the perforation. We don't know where the perforation is. Understand that? Ultrasound man will say there's definitely air in the peritoneal cavity. and you open up, you find a single perforation. With the healthy bowel, you always do edge biopsy to make sure not dealing with typhoid fever. Closure transversely is the answer. And you send the blood for typhoid test, all of them will come out negative. These are patients with a good prognosis. I must go back. Morbidity and mortality. Please remember patients who develop the typhoid perforation. The rest of lymphoid patches are areas where adhesions can occur. If you have heard about a gentleman called Harold Illis, his concept of adhesions is ischemia. This is any ischemic bowel wall invites adhesions. And these are patients who can come back to you with adhesive obstruction at a later date. That's why I mentioned the word morbidity. Mortality, as I said earlier, even in good hands, the best figures are 20% mortality, extremely high, only because of delay in diagnosis. Today, typhoid fever, properly treated, should not reach the stage of perforation. But surgeons, we do see them, we must be familiar with them, we must know exactly how to treat them. Very little portion remains, but interesting. Now look at the difference in the picture. Can you look at the healthy bowel all around? Are you impressed with this single perforation? Looks very healthy. There's hardly any necrotic area, and the rest of the bowel is very healthy. This is what a non-specific ileal perforation looks like. They do extremely well with surgery. Now, this is something that you see sometimes in the, you have a clinical diagnosis of peritonitis. Ultrasound man says there's no gas. Sometimes the picture may look more like a subacute obstruction. You open up the abdomen, you find, or you put a laparoscope in, you find dead roundworms in the peritoneal cavity. Explain. More often than not, these dead roundworms are rounded up by the abdominal policemen. Great omentum, you'll find the great omentum will be hiding. You just unwind the great omentum, you'll find dead roundworms within the great omentum. You look from DJ flexure to the ileocecal junction, looks absolutely healthy, normal. No congestion, no ulceration, no edema, healthy bowel, dead roundworms in the peritoneal cavity. Explain. Explain. Yes? Deepak Sharma. Quick. Answer is we do not know. Many people believe that roundworms, see, roundworms are the greatest migrants ever seen inside the abdomen. I compare them to Marco Polo. I don't know how many sites, have you seen roundworms coming out at unusual openings? One, you should know as a surgeon, the commonest migration is into the common bile duct. And like, you know, many of the Hindi movies, Nagina and company, more often than not, you find a pair of roundworms. Invariably, when I pick up a roundworm from the common bile duct, I always look for one more. And more than 90%, its mate is there, a friend is there, whoever it is. You'll always find more than one roundworm sitting inside the common bile duct. Which are the other unusual sites? Come on, tell me. Come on. Then I'll tell you my stories. You tell me now. In fact, my professor once opened up a patient, you know, these are pre-scan ultrasound X-ray days. The patient chronic pancreatitis, and lucky those days we used to identify the duct only by looking at the site and putting a needle in. The moment you aspirate pancreatic juice, you know you got a pancreatic duct there. And the professor was planning to do a lateral pancreatic jejunostomy. And he put a needle, he opened up the duct, and he found a large roundworm occupying the entire pancreatic duct. If those of you who have gone to Padmanabha Swami temple in Trivandrum would know what I'm talking about. Lord Sriman Narayan lying on the Shesha. So like that, the pancreatic duct was like a bed for this roundworm. We extracted the roundworm, nothing else was done, no lateral, nothing. And the pancreatic opening was closed. But much more interesting, I had a patient whose roundworms came out through the penis because he had a vesicoenteric fistula following tuberculosis. I have seen a patient with a perforated eardrum with a roundworm coming out of the ear. So they are great migrants. And there is a school which believes that roundworms can migrate through the wall of the peritoneum and of the bowel. But that opening gets closed so quickly. By the time the surgeon opens the abdomen, there's no evidence. I don't know, but I have seen patients with absolutely healthy, normal bowel with dead roundworms. They're very interesting clinical situation, right? Now, other measures common for all ileal perforations, I think all perforation, good peritoneal toilet. Remember sites where they're likely to accumulate paracalic gutters, pelvic abscess, etc., etc., and keep adequate drains. You must wash out the peritoneal cavity until the returns are very clear. Don't allow any pus to remain. Despite that, these people are likely to develop complications. So of course, one is sepsis can lead to multi-organ failure. Patients come late. Despite your best efforts, you're likely to lose some patients. Intra-abdominal. Pelvic abscess, how does it manifest? How does pelvic abscess manifest? This is my last slide. So I'm
Loose stools. Loose stools.
What's the cause of loose stools? Excellent answer.
Patient will have diarrhea
Irritation.
Rectal irritation.
What?
in the pouch of Douglas.
Pouch of Douglas irritation.
Rectal irritations.
Rectal irritation produces tenesmus for a kind information. This is some of these wrong answers seem to be pan-Indian. I don't know why. Yes, please. Pouch of Douglas, a female vidya. I mean, let us say it's a male. Diarrhea is correct. It is because the loop of ileum is in contact with the pus in the pelvis, and that leads to a diarrhea, not rectal irritation. Remember that. Understand? Today, of course, you put a finger, you'll find a boggy mass anteriorly, confirm it with an ultrasound. I have seen a pelvic abscess presenting a suprapubic swelling. It is so large that it has pushed the bladder and come behind the anti-abdominal wall. Things don't get delayed so much. How do you treat a pelvic abscess? How do you treat a pelvic abscess?
We can go for transrectal.
You can. I never like the word surgeon. Huh?
Image guided aspiration.
Image guided through what route? Anti-abdominal wall.
Transrectal.
Huh?
Transrectal.
Huh? Transrectal. You put a whiteboard needle.
Yes.
Image guided. What do you want? Why image guided? Okay. You put an image guided needle. You draw clear urine. Remember, no pelvic abscess should ever be treated without emptying the bladder. If the patient says, doctor, I've just gone to the toilet and come back, means nothing. Make sure the bladder remains absolutely empty before you do. Usually, needle drainage may not be adequate. All that you need to do is give the patient adequate general anesthesia with relaxant. Remember, anal procedures are very, very painful. I've seen a patient ending up with a near cardiac arrest. So don't ever try simpler measures. Have a proper anesthesia, relax, and then insert a blunt tip sinus forceps into the boggy mass. You find lot of pus drains out. Keep it drain. Of course, the drain usually comes out by its own in about 48 hours time. Pelvic abscess gets drained completely. You have to drain. Understand that? Now, other space which is taught in the earlier lot, but today has become less common, is subterranean spaces. Olden days, pus somewhere, pus nowhere, think of subterranean space. I think no longer this statement is valid because of ultrasound can pick out the space and you can drain. What's the ideal drainage? Subterranean space?
Through the 12th rib.
Depends upon the location. If you're in an anterior space, you can't go. What you're talking, traditional extra-pleural, extra-peritoneal, ideal. Both the bed of the 12th rib and you're below the pleura, above the peritoneum, you can drain. But today, I think most of it get drained by the ultrasonologist and they put a pigtail catheter and drain the subterranean space. I don't think surgeons have very much to do in subterranean collections. What worries more is localized collections between the leaves of the mesentery or between the bowel lobes. Ultrasound is the only way you can diagnose patient's condition deteriorate. Abdominal findings in the post-op period are very difficult to make out because tenderness is already present, rigidity in typhoid is absent. So these are diagnosed only with the help of investigation. This may be one more place for a CT scan for you to do. Pick out the exact location and treat them. Days gone by, these were missed, or surgeons went in the process, damaged the bowel. It's already edematous and friable. Many of these localized collections ended with a fecal fistula. That's the reason I added this. Be careful when you deal with localized collections. Don't produce damage. These damages are not recognized on the table. They're recognized well and good. You gently try to separate, but you have to realize how friable it is only when you make a hole. Till then, you won't know. If something contents come out, then you treat it, externalize or do whatever you want. But some of them can be missed, and post-operative, when they come with a fecal fistula, you know it's got. The other thing is, if in a typhoid perforation, you have missed an impending perforation, they again can develop, may not be a general peritonitis, again a localized collection. These are need gentle care, proper radiological guidance before you undertake to treat them. That's the message. Okay. So carry home message today is that typhoid perforations are very much unlike perforations in the rest of the small intestine. The problem is unique, clinical picture, manifestation, management, everything you got to know in detail. But unless, of course, end up in New York and Los Angeles, you can tend to forget about it. Most of you will end up in this country only. So you got to be very familiar with typhoid perforation. Okay? Any doubts?
Sir, peritonitis and peritonism. You said like in case of peritonitis, there will be a peritonism. Sir, I'm not getting the difference between them. Please.
This is a problem I'm trying to tell you. There are situations where peritonism and peritonitis cannot be clinically distinguished. Rebound tenderness means inflamed peritoneum, nothing else. It can be due to a perforated ileum with the contents causing inflammation. Now, first of all, one question I want to ask you earlier. What is the surface area of the peritoneum like? How many square meters? Surface area of the peritoneum. MBBS level question.
1.7, sir.
Who is this? Miss Saital, is it? Come on, identify your name, please. All human beings from King Kong down to a puny little human being. Is there a simple formula for calculating the surface area of the peritoneum? Simple means absolutely simple. Oh, great. I come down to third year MBBS. I'm sorry, first year MBBS, when you learn the peritoneum. Quick, quick, quick. I want 10 seconds. I'm already 3:07. I want to finish by 3 o'clock today. Come on, 4 o'clock, you go to some PG clinics. Quick. Purposely, I laid you down the garden path, madam. It's not measured in square meters. The simple answer is...
Centimeter square, sir. 1.7 centimeter square.
Meters by 1 meter.
Come out of a clone, is it? Every human being is a clone, is it?
1 to 2 meters squares.
I'm very happy. The imagination is going. Today's auction seems to be always in the upward direction. Congratulations. The easiest way is the answer is the surface area that of the skin. I'm mentioning this because when you look at a peritonitis patient, you must compare that patient with a person who has 100% burns. Then only the gravity enters your gray cells. Understand what I mean? The total surface area of the peritoneum is equal to the surface area of the skin. So
it's 2 meters square.
So comparable to a person with 100% deep burn. You know what the mortality is. So when you salvage a patient with peritonitis, you must thank the Lord for saving this patient, because how many of 100% burns in this country survive? Practically zero. So I want you to understand the gravity in this fashion is equal to the surface area of the skin. I should ask this question much earlier. Anyhow, right? Okay. So peritonism and peritonitis can extremely be difficult. If the patient is already in the ward under proper treatment, it's safer to wait. Today, ultrasound is a very good guide. When in doubt, do a CT and make sure there's a perforation. If there's no perforation, treat them conservatively. Primarily, what I'm trying to tell you is surgery for type of perforation itself is adding insult to an injury. It is not like a duodenal perforation where patients come pretty healthy You close the perforation, everything went well. They are very sick patients, and you're adding anesthesia and surgery is adding insult to injury. That is the carry home message. Okay, good. Very good question. Thank you.
Sir, can you explain the reason for loose stools in pelvic abscess, sir?
My dear girl, when there's a loop of ileum lying in the pelvis, it undergoes paralytic ileus and undergoes a, you know, there's translocation of bacteria. You're aware of it, no? There's translocation of bacteria, and this produces diarrhea. It's the ileal diarrhea and not the rectal diarrhea. Understand that?
Yeah, sir. Thank you.
Right. You
Sir.
don't think you're convinced.
Hello,
Are you
sir.
convinced, or you're just for my age, such an old man, how dare I speak against him, is it? Is that the attitude, or you're convinced? Okay. Any more questions?
Hello, sir.
Uh,
Sir, in duodenal and gastric perforation, only vascularized omental patch should be used, no, sir?
Exactly. There's no question of performing a band, Baba. You're wrapping,
Sir.
see, you are bringing the momentum with this attachment completely. You don't divide it at all. You swing the amount of momentum. See, for example, at one stage, hydatid to the liver, one of the methods was to pack the cavity.
Omental patch.
With those areas, you hardly have any compressive effect. Here, that's why I said, how much of you need a loop, a portion of ileum, which may be maximum about 2 inches in diameter, nothing beyond that. You bring the terminal portion one side, just bring it up, and there's no bowel in between. The transverse colon is capable of looking after itself. It doesn't get compressed by the omentum. It's a small bowel, it gets compressed with omentum. That's why taking the omentum to the right iliac fossa carries a risk of constrictive obstruction, because the loop of bowel can get, in fact, I didn't want to mention that post ileotransverse colostomy, I had an interherniation leading on to gangrene, because I've taken a loop between the mesocolon and here, there is a loop of bowel that got caught and was gangrenous by the time they came from 100 miles away from Mangalore. So bypass surgery and resection should be restricted to the smallest number possible. Try to get away with simple closure and inversion of the remaining lymphoid patches than going for more drastic measures. But if you're forced to do it, no other option. Right. Okay.
So I have one question.
Yes, please.
Sir, anastomosis just proximal to the IC junction, maybe 10 centimeter, 15 centimeter. Do they always have to be protected by a proximal stoma, or?
Depends upon what condition you're operating for. As long as the bowel is healthy, small bowel anastomosis, provided the vascularity is good, there's no harm at all. I mean, these are technical details. See, what happens when you cut the bowel, make sure that you take more of the anti-mesenteric border. You never cut the bowel at right angles to the lumen. You understand what I mean?
Yes, sir.
You oblique cut, because the anti-mesenteric border is the least vascular in the bowel wall. So cuts are oblique on either side. And as long as you release the clamps and see that the edges bleed very well, there's no need for proximal ileostomy. Remember, ileostomy in this country cannot be taken very lightly. You have fluid electile balance, nutritional problems, so many problems are there. Avoid an ileostomy.
Okay.
One thing at this stage I want to mention, cecostomy is not something we done as far as drainage is concerned. A defunctioning procedure, cecostomy is bad. Understand?
Yes.
Cecostomy is only drains the cecum and nothing but it's one of the most selfish organs. When you do a cecostomy, the cecum drains, nothing else. You prefer an ileostomy rather than a cecostomy. Proximal diversion depends upon the site and the disease. A disease where vascularity is compromised, you have to be really careful. But small bowel vascularity stands a lot of nonsense on behalf of the doctor. Unlike the large bowel, where you have to be much more careful. Small bowel anastomosis, even in not very experienced, hardly ever leaks. The leakage rate is very, very low. As long as vascularity, you make sure the vascularity is proper.
Hello, sir. Sir, we open up the abdomen for to repair a perforation, sir, and we find live worms there. Should we try to remove as many as possible, or sir, we have to just close the perforation site
The
and
question
and
is,
remove the
wait,
live worms at the
are we
site.
talking about roundworm obstruction or roundworm perforation? First question. Are you talking about the patient referred where bowel looks very healthy, you find dead worms in the peritoneal cavity, nothing. You can deworm them at your own pleasure later at the time. Your question, is it related to roundworm obstruction?
No, sir, perforation, sir. Is there
See, unfortunately, roundworm by themselves, I have not seen a perforation where you can see a roundworm coming out of the hole. I have never seen that. I have seen roundworms with intact bowel. Roundworms by themselves, if they cause a perforation, I'm told, I mean, there's no evidence, there's no experimental evidence or proof that the roundworms can migrate across an intact bowel wall. The perforation gets closed spontaneously and the bowel returns to normal by the time the surgeon goes in. So the situation you are mentioning is not met with in practice. Understand what I mean? You may find some, if the patient has a perforation due to some other reason, you find some dead roundworm, take it out. Don't do anything else.
Okay.
Now the question, sorry, I think it's time for me to stop because roundworm obstructions will take another 15 minutes easily. I don't think Radhakrishna will permit me. Am I right, Radhakrishna? 3:15 now. I better stop.
Okay. We'll have intestinal obstruction as the next class.
Huh?
Intestinal obstruction.
Sir.
What is this? This seems to be ongoing. Intestinal obstruction as a topic for full-term discussion.
Or any topic of your choice, sir.
I have no choice. I think my quota is over.
No.
Huh?
No. Intestinal obstruction is a big area, sir.
Give me a little time. I'll think about it and come back to you.
Okay, sure, sir.
Huh? Right.
Okay, thank you so much, sir, for a wonderful
Thank you, sir.
Okay, thank you. Thank you.
Thank you, sir.
so much, sir.
Thank you, sir.
Thank you.
Thank you, sir.